My name is Dr.Antarra Singh and I'll be teaching suturing techniques.
Before we begin, let's review the essential tools for suturing. Here we have the tissue forceps, often with teeth, which help stabilize and gently evert the skin edges. They should guide the tissue without crushing it, held in a pincer grip between the thumb and the index finger. Next, we have the suture scissors, which are used to trim the suture tails close to the knot. They're held like the needle holder with fine, deliberate cuts. Next, we have the needle holder or the driver. It is used to grasp and guide the curved needle with control and precision. It should be held with a tripod grip, same as the suture scissors, using the thumb and the ring finger, and the index finger to help stabilize the needle driver. Finally, the suture material itself. Typically, we use monofilament nylon or propylene for skin, and absorbable sutures like Vicryl and monocurl for buried or subcuticular closure. Let's start with simple interrupted sutures. Pick up the needle in the holder about 2/3 from the tip, keeping it at a perpendicular angle to the needle driver. We approach the skin at a 90-degree angle. Stabilize the near edge with forceps and enter approximately 3 to 5 millimeters from the wound margin, following the needle's curve. Bring the needle through and exit the opposite side at an equal distance. We then pull through, leaving a short tail. Then we tie a flat, square knot in a 2-1-1 fashion. First, with a surgeon's knot, 2 times over the needle driver. Then once in a reef knot in the opposite direction. And then one more loop in another reef knot in the opposite direction. Keep the knot lateral to the wound and seat the knot gently and cut the tails approximately 3 to 5 millimeters. Space the next suture roughly 1 bite width apart. Simple interrupted sutures are used for precise edge approximation. The materials used normally are non-absorbable monofilament like nylon or polypropylene, and the indication for such sutures are skin lacerations, excision sites, and wounds which need individual suture removal in case of infection. After the last reef knot, pull all the instruments to one hand. We don't drop the forceps, instead we palm them, and cut using the scissors in the other hand. Next is the horizontal mattress suture, which spreads tension laterally and protects fragile skin. Pass the needle across the wound 5 to 7 millimeters from the margin and exit to the opposite side. Next, we want to turn the needle in the opposite direction on the needle holder to throw a backhand suture. We then re-enter on the same side approximately 5 to 7 millimeters lateral to the first exit and cross back to the opposite side. The loop will lie horizontal to the incision. We now gently tie off the suture in the same 2-1-1 fashion with 2 surgeon's knots, 1 reef knot, and another reef knot in the opposite direction. We want to make sure the suture is not too tight, as we want it to distribute tension rather than strangulating the tissue. We can place protective bolsters under the suture if the skin is very thin. We normally use non-absorbable monofilament like nylon or polypropylene for this kind of suture. We use horizontal mattress sutures on fragile or atrophic skin, such as in the elderly, or in areas which need tension distribution, like the back of the hand, or as a temporary strong fixation. Next is the vertical mattress suture, also known as far-far, near-near suture. It combines deep support with superficial edge eversion. For the first pass, enter 5 to 8 millimeters from the edge and take a deep bite across the wound. Exit on the opposite side, making sure to be equally far from the edge of the wound. Then we backhand the needle, and for the second pass, we take a superficial bite about 1 to 2 millimeters from the edge of the wound on the same side and exit equidistant on the opposite side to approximate the epidermis. We then tie down the stitch with the surgeon's knot. Followed by a reef knot. and another reef knot. Avoid over-tightening to prevent ischemia. We then trim the tails, and we can add bolsters if the skin is too fragile. The stitch will lie perpendicular to the wound. We use non-absorbable monofilament like nylon or praline for the skin, and we avoid overly bulky braided sutures. Indications for vertical mattress include wounds which are under tension, such as the thick dermis, like the scalp or the back, where edge eversion is needed. Next, we have the running subcuticular stitch with the Aberdeen knot. We use these stitches for an elegant, secure cosmetic closure. We start with a buried anchor knot at the proximal end. Take a bite, deep to superficial. Tie off the knot with a surgeon's knot, followed by a reef knot and another reef knot. Next, we run the suture in the dermis with small, even bites, creating a somewhat S pattern. We maintain a consistent depth just beneath the epidermis. It's helpful to keep the needle in the needle driver at a slightly larger angle than 90 degrees. It makes it easier to take superficial bites. For each bite, we want to enter at the same level or slightly behind where we exited on the opposite side. For all subcuticular sutures, we do not exit the epidermis. We want to keep the suture within the dermis.
For faster suturing, grab the needle with the needle holder as soon as you pass it through. Once we reach the distal end, we don't pull the thread all the way through. We need the loop to create the Aberdeen knot. To create the loop, we want to go deep to superficial. Place your thumb and index finger within the loop and pull on the thread without passing the needle to create a knot. Repeat this process 3 to 4 times. You can use your ring finger to help pull the thread. On the last pass, pull the needle through the loop, creating the last knot, and then tighten. The knot locks the suture line and will sit neatly within the suture. Then we place the needle back into the needle driver and we take another bite at the distal apex of the wound, and we exit through the epidermis close to the edge. Now cut the tail flush to the skin. No external knots will be apparent. Next, we have the buried knot, or the deep dermal knot. It closes dead space and offloads tension from the skin layer. We normally use absorbable braided like Vicryl or absorbable monofilament like monocryl or PDS sutures, depending on the required longevity. We pass the needle deep to superficial on the near side, and then superficial to deep on the far side, so that the knot will lie beneath the incision. We tie off the suture the same as all other sutures, but we will tie it off parallel to the incision, not horizontal. So with the surgeon's knot, followed by a reef knot in the opposite direction and another reef knot in the original direction. Then we gather the instruments in the left hand or your dominant hand, and you want to cut flush to the incision, so the knot will be within the wound. We place the sutures from the apex of the wound, working our way towards the middle. Next, we have the running suture, which is fast and efficient for long wounds. We start with a simple interrupted stitch at the start, and we tie it off. This is your anchor. Now place the needle back into the needle holder and take equal bites about 3 to 5 millimeters from the edge of the wound, advancing 5 to 7 millimeters per pass, and we maintain even tension to avoid blanching. The bites should be taken straight across the wound. You want to secure the needle with the needle driver
as soon as you pass the needle through to the other side. This way, the running suture moves faster. Keep the needle throw consistent so the wound everts evenly. Once we reach the last throw, don't pull the thread all the way through. We use the loop to tie off the suture. Make a surgeon's knot, followed by a reef knot and another reef knot. We then move all the instruments to one hand and trim the tails of the suture. And we inspect the wound for uniform eversion along the line. Next, I'll demonstrate an instrument tie and a hand tie. Pass the needle through to the opposite side. Then we palm the forceps. Keep the needle holder parallel to the incision. You have a shorter end and a longer end. Your longer end is known as a working end. Make 2 loops over the needle driver to the opposite side from your body. and then pull the shorter end towards you. Then in the opposite direction, we make a reef knot. With only one loop going over the needle driver, we grab the shorter end and pull it away from you. Then we make one more reef knot, but this time in the opposite direction. Make sure the knot is tight enough, but not too tight so as to cut off the circulation of the skin. Then gather the instruments in one hand and trim the tail. Next, we have the hand tie. Grasp both the threads between the thumb and the index finger of each hand. Try to make sure that the threads are of equal length. Then you take your middle, ring, and pinky finger and go over the pinched thread. You then want to grasp the thread on the other hand between the ring and the middle finger and pull it under the pinched thread between the thumb and the index finger of your right hand. Push down the knot with your index finger just to make sure that it's tight enough. Once again, pinch the threads between your thumb and index finger. Then, using your middle, ring, and pinky finger, flip each of the threads, either the right hand or the left hand. Then, place the thread on the opposite hand over the three fingers on your left or right hand. Then, using your middle finger, pull that thread under the thread in your dominant hand, pinching the thread between your middle and ring finger. Pull it under, and then secure the knot using your index finger. Place 3 to 4 of these knots using first the right hand or the left hand, whichever is dominant, followed by your non-dominant hand. So once again, pinch the threads, flip the 3 fingers over, using your middle finger, cross to the other side, pinch between your middle and ring finger, and form the knot. And then repeat on the other side. Under, through the loop, and then down, forming the knot.